So there's some things on here that support the exemplars that we're learning. They might not be specific like the exemplar itself for my students, but they're things that you need to know in mobility as a nurse. So let's get started. Looking at this slide, it's the do's and don'ts with CAS care. There's different things that we're going to look at. So we're going to move forward. I won't read all the theory objectives. You can read them yourself. But I think that this will be a very good lecture to help you really move forward in understanding nursing and mobility. So again, more theory objectives. I'm not going to read them to you, but go ahead. You can read through yourself. And here we go. Let's get clinical objectives. They're here too. Everything we learn in class, we need to now think about and apply in the clinical setting. So these are objectives that we hopefully you will have understood and learned as we go through this unit. So there's different things that happen. You can sprain an ankle or you can strain your back. So let's just talk about sprains because they happen every day. You did it as a kid, especially. We see a lot of children with sprains, adults too. A sprain is the partial or complete tearing of the ligaments that holds various bones together to form a joint. So that's what we sprain. So that's why sprains take a long time to heal. I used to tell a lot of people back, it's better to have a fracture because a fracture seems to heal faster than a sprain because we're dealing with ligaments and ligaments have to heal. So it takes a while. A sprain occurs when a joint may be forced during trauma. It's past its normal range of motion and there may even be twisting. That's why lots of times people will say, I twisted my ankle or I twisted my knee. They're talking about this. They're sprained. There's something that happens. They turned it, went outside of the normal range of motion, and then injury happened. And with injury comes inflammation and pain and all of that, and then healing has to take place. The ankle, knee, and wrist are the most commonly sprained areas. So we see it with wrist a lot, but think about that. Ankles support our body to our feet, knees are, we walk, knees take a blow every day. Every time you're taking a step, every time we climb something, those knees, the wear and tear. And the wrist, of course, because we're moving, grabbing, twisting, using our hands and arms to do things. So it makes perfect sense. These would be the three high areas of sprains. So there's different grades of strains. We have mild, moderate, and severe. So a mild strain, ligament fibers are stretched slightly. There might be a very small tear. The ankle may have minor swelling and tenderness, but it will feel stable. And walking is usually possible with minimal pain. And with proper care and rest, a grade 1 sprain usually heals within about 2 to 3 weeks. A grade 2 or a moderate sprain, the ligament is torn, but it isn't a complete tear, and that's what you need to put in your notes. It's not a complete tear, but it's torn. The ankle may have swelling over the injury, bruising, and it hurts to move it. The joint remains fairly stable, but the affected area is tender to touch. A grade 2 sprain may require additional treatment to heal and can take 2 to 6 weeks to completely heal. And then, of course, a severe sprain, a grade 3, the ligament is torn completely. The ankle has significant swelling and bruising and is unstable. Walking is likely not possible because the ankle gives out and there's an intense pain. So there's 3 different grades to sprains: the mild, the moderate, the severe, and that's a 1, 2, and a 3. So there's ankle sprains. This is a great picture. There's inversion, eversion, and a high ankle sprain. And if you look at what's happening, the ankle turns out and we have our tear here, if you can see. Then if you look at the eversion, the foot is going, the ankle's coming in and we'll have an inward tear on that side. That's where we're seeing it. And then the high ankle sprain is up above that, and you can see it goes all the way around. See the around motion, and we can see the injury there. So this is a great picture to look at to kind of show you what's going on. And these are great terms to understand: inversion and eversion, and then a high ankle is all the way around. Like I said, grades of sprains are different. We have grade 1, normal, grade 1, grade 2, grade 3, right? Mild, moderate, and then, of course, the worst. So the thing that I love is pictures, because pictures just show it for me. I need somebody to show me something in a picture form. I just like it. It just seems to sink in easier for me. So if you look, we have this turned out sprain. We see the tear over here. And if it's normal, do you see how this ligament is together? Then a grade 1, there's a slight tear. There's the redness. You can see the injury there. There's stretching and small tears in it, but it's stable. And that's why there's minimal pain. They're able to walk, all of those. Then if you look at the grade 2, once again, there's a small tear. It's a tear into the ligament. It's going past that minimal mark. It's a pretty good sized tear, but it hasn't completely torn through. It's a larger tear. And the injury is greater. The tear is bigger. So we're going to have more swelling, more pain. You know, all of those things that were on that previous slide. And then grade 3 is a complete tear through, and you can see it. There's a complete tear through here. You've got swelling, and this takes so much longer to heal. It's a complete tear, and it has to, you know, other things have to happen, but it will have to be have the time to heal back. And they cannot walk on this. It's unstable, and they're having a lot of issues. I love this picture. It's a great. So sprains, how do we diagnose them? With a physical exam, we're going to look at them. We're going to we'll feel for pulses. We'll look for swelling. We listen to what the patient says. What happened? What happened? And they'll tell us and explain it to you. Also, we'll do an x-ray. We want to rule out a fracture, because there are times that bone can be involved, and it's no longer a sprain. It becomes a fracture. The bone is involved. And so but you can have a sprain and a fracture. We can have ligament and bone involvement. So it just depends. And it will also, the x-ray can show us if there's anything else going on with the joint that's sprained. So what do? We rice. We rest, ice after injury for 24 to 72 hours. We compress, that's your C, snug elastic bandage, careful not to cut off circulation. We should be able to put our fingers up under it. It shouldn't be so tight. We should be able to feel a pulse up under it. There should be no numbness or tingling. If they can tell you that, they should be able to. It's a different feel when you're cutting off circulation. Also looking at warmth and color of the extremity parts that you've that are below where you've wrapped this elastic bandage, where you've created the compression. But what does compression do? It's going to help with the swelling, right? It's going to help with that swelling. So we want to compress it. Now, when you're wrapping, I want to make sure I explain this. When you're wrapping an ankle, when you're wrapping anything, you don't want to wrap downward towards the hand, or downward towards the bottom of the leg, or downwards toward the foot. You always wrap from bottom and work your way up. Why? Because of circulation. If you're pushing stuff down, are we going to create issue? Yes, we can cause more swelling below it. We can blow those toes up. They're going to look more like sausages. So what we want to do is start down with our initial wrap and move it up. And the reason why is that helps push circulation up. It helps with fluid going up and helps with that swelling. And then, of course, elevation. We'll prop up pillows, get it up. We want to elevate it, and that's also going to help with the swelling. The more inflamed and swollen it becomes, the more uncomfortable it can become. So we want to make sure we rice it. So we rest it. We're not going to go out and play more whatever we were doing. We're going to ice it for 24 to 72 hours. Remember, when we're icing anything, we need a barrier underneath it so that ice is not directly onto the skin, because that will burn the skin. It can cause a lot of damage. And also, too, We have that Burial washcloth, something you can put in then your ice pack so that we don't have that direct contact. And then also putting it on and taking it off. You don't put it on and leave it on for 24 hours. It cycles. So we go on and then off. Okay, so just remember that. Talked about the compression and the elevation. This is a grade 2 or a 3. We want to rest the joint. We're going to give them crutches for lower extremity sprains. That means they're not able, it's not stable in 2 and 3. They can't go walk. They're going to be unstable. There's a lot of discomfort, so they need the crutches. They're going to rest that joint by using crutches. They're not going to be walking on it. They're going to let the good leg work and the crutches work to keep them mobile. Non-steroidal anti-inflammatory drugs, NSAIDs, around the clock for a couple of days. NSAIDs are going to help with the inflammation and the pain and the discomfort, and they're much needed. What do we know about NSAIDs? You got to eat. They rip your stomach up. We need to make sure that we eat with them, that we don't exceed the maximum dose in a 24-hour period, and that they drink plenty of fluids. These things, look at their renal function, look at things that are going on, because NSAIDs can be quite harmful if we're not careful. They also can act and help with bleeding issues. So we don't really want to be giving tons of NSAIDs to someone who is on Coumadin, warfarin, or someone that's taking any type of anticoagulant. We need to be very, very careful. So it needs to be prescribed by the doctor, the physician, if they have other comorbidities where there's issues and they take blood thinners or anticoagulants, things like that. But NSAIDs are our friends when it comes to sprains. They're a good thing. So the next thing we're going to look at are strains. So we've got sprains and strains. Now, strains are tearing of the muscle, a tendon, or both. That's the difference. So we're looking at ligaments with one and muscle and tendons with the other. So they occur by trauma, overuse, or overextension of a joint. We can strain elbows by playing golf and tennis. We can strain our backs by lifting things and using improper body mechanics. So strains are a different ballgame where we're tearing muscle, tendons, or both. So how do we actually diagnose these? Looking at signs, symptoms, and diagnoses. So history of overexertion. If you've been out playing golf, you play for the PGA or the LPGA, and you're out there every day hitting golf balls, you're going to be straining, your possibility of straining your elbows, straining your shoulders. You could even be straining knees or other areas, because we walk, we turn, we do all of these things. Now, it could be a strain or it could be a sprain, and that has to be decided. There's soft tissue swelling, there's pain, and if there's muscle, there will be bleeding if the muscle is torn. The muscle will bleed. And with bleeding, what do we get? Bruising. So we're going to treat them again with ice and compression. It should be immediately applied and the part should be rested. No ands, ifs, or buts. The patient is taught to use ice for 20 minutes out of the hour only. This is what happens. What does ice do? It vasoconstricts. So if you put ice on something that's cold, it's going to vasoconstrict. Well, we need blood flow to heal things. You got to have blood going into it. So we put ice on for 20 minutes out of the hour so that we can handle and work with the inflammation of it and also the pain and discomfort. But we've got to get things flowing there so that it can heal. When compression is used, the distal parts of the extremity must be checked for sensation and adequate circulation. Now, I'm going to tell you, this is talking about RICE. It goes back to that. We're going to rest it, we're going to ice it, we're going to compress it, and we're going to elevate it. This is talking about with a strain. This is where we have that muscle involvement, could have muscle tearing or tendons or both. If that is the case, we need to do this immediately. There's no ands, ifs, or buts. It needs to be ice and compression immediately. but we need to be checking, no matter if we wrap a sprain or a strain, we need to be checking for sensation and adequate circulation from the distal parts always. So we have dislocation and subluxation, stretching and tearing of ligaments around a joint with complete or partial displacement of a bone. So now we're dislocating something. Something is out of alignment, right? And that's where we're looking at dislocation and subluxation. So we have the history of an outside force, signs and symptoms, history of an outside force, something's caused this. Severe pain aggravated by movement, muscle spasms, abnormal joint appearance, it's going to look weird. And radiography, we need an x-ray to look at what's going on so we know. So let's talk about fractures. So looking at the etiology and the pathophysiology of it, it's a break or interruption of the continuity of a bone. So somewhere in a bone, there is a break or something that's interrupted the continuity, the flow of that bone. Trauma can cause it. We get in car accidents, we fall, we can break arms, we can break legs, we can break necks, backs. Wherever a bone is, it's a possibility that it can be fractured due to a trauma. There's crush fractures, where that's what happened to my son's finger recently. He was on a lift at work and it was going up and it crushed in his work glove, his middle or his pointer finger, and it literally ripped the tip, this core part of the tip off, and crushed the tip of the bone. Everything's healing. They didn't do any surgery, but it's considered a crush fracture. And it was pretty, it was worrisome. We thought they might have to cut the tip of his finger off, but ended up everything was good. Osteoporosis and metabolic problems can cause fractures. So if we deplete our bones and they become quote unquote brittle, we can have fractures that just take place. We can have hip fractures. There are people that have small little fractures throughout their spinal cord. It's very, very painful. So there's a lot of things. And metabolic problems. If we're leaching calcium out for some reason, cancer is one that can cause the bones to become brittle. There's other disease processes out there that can cause these problems. And then mechanism of injury can provide clues about the type of fracture. So if we have a T-bone, a car hits the side, T-bones the side of a car, we take direct impact to the femur, the side of the femur. So lots of times in T-bone accidents, we're trying to understand that there's most likely a femur fracture. It's a possibility. If we're head on, we're going to look sternal. We're going to look at anything that pretty much hit that steering wheel. And if you fall, what do you do when you fall? You put your arms out, don't you? You try to push your arms out to catch yourself, and that's how we break collarbones and arms and different things. So mechanism of injury is huge. We want to know, did they fall 12 feet off a ladder, off the roof of the house, or did they fall across, walking across their kitchen floor? It's a possibility. So that's mechanism of injury. If they are hit with a ball bat and they're fractured that way, there's different things that can happen. And then we have degenerative issues with our body. I have that right now with my neck. I have arthritis in my neck, and there's a lot of things happening with that bone. It's breaking down. It's just not as good. So I have pain and discomfort in it, and I have to go see a physician to help with that. So not fun. Let's just go with that. So minimal to severe pain depending on the type of fracture. Usually fractures hurt. I mean, I've never had anybody break any bone and go, it doesn't really hurt that bad. I mean, honestly, I've broken my finger, and it hurt. I thought it was pretty painful. I've not broken any larger bones or anything like that, but I've seen a lot of fractures out there, and never has anyone said to me once that it's not bad. Most people are in a lot of discomfort, so we need to understand that. So what do we want to do? Is we want to make sure that we get all the information. We want to make sure that we know everything before we start to medicate, but we do need to give them pain medicine. They can have swelling or bleeding with fractures, just depending on where the fracture is and what kind of injury. There's tenderness, deformity of the bone, ecchymosis, crepitation with any movement. You hear that? That's, yeah, it's not pretty. And loss of function. You break your arm, you're not going to use your arm. It's going to hang there or swing there. Same with your legs, same with anything. It's just not going to function the way it should. And you're going to lose that function. So if you have, and there's different fractures, and we're going to go over them. How do we diagnose a fracture? Well, we can do a physical exam. If you've got a bone and there's deformity, you can see that the bone, you can see that there's deformity, you can see something's wrong with them. Hip fractures, when little old ladies or little old men fall and break those hips, they'll draw, one leg will draw up. So that's how we can physically look, and then X-ray. X-ray is going to tell us everything. A bone is a hard substance. It shows up. We can see all the different fractures, whatever fracture we have and what bone and what's involved. The main thing with a fracture, wherever the bone is broken, especially in the extremities, you want to make sure that you have a distal pulse. Put that in your notes. You need to know you have a distal pulse if you have broken any part of your arms, any part of your legs. The other thing we want to do is, or foot or whatever, below, we need a pulse because that means there's blood flow. If we're impeding the pulse and we've caused something to block or not have a pulse because of the fracture, that is emergent. We need to immediately do something and intervene. And that's where traction comes in. We pull things and hopefully get a pulse before they get to the OR, because without blood flow, tissue dies. Simple as that. So X-ray and physical exams, how we look. So there's different fractures. We have a complete fracture, an incomplete fracture, a comminuted fracture, closed or a simple fracture, an open compound fracture, or green stick fracture. Couldn't get that last one out, sorry. But they're different. We're going to look at pictures so you can understand what they are, because you're going to hear that. Oh, it's a simple fracture, or it's a closed fracture, or you're going to hear compound fracture, and that's an open fracture. And we'll talk about all of this and look at the different pictures of what the fractures look like so you'll understand what they mean. So there's different kinds of fractures. The pathologic fracture, and a pathologic fracture is a broken bone caused by a disease rather than an injury. So there's something that has caused the bone to weaken. It could be a benign or malignant lesion, that's cancer, metastasis of cancer, or metabolic abnormality, making it more likely to break. That's what this is. A longitudinal fracture is a break in a bone that runs along the bone's axis. So it's going downward, if you can see the picture. It's most often used to describe long bone fractures, but the term has also been used for temporal bone fractures. Where's your temporal bone? For my students, look it up. For you guys, look it up. But this is where we say longitudinal. And then, of course, there's spiral fractures. And spiral fractures, as you can see, those little arrows are going around in a spiral-like movement. It's a twisting. It's a complete break in a long bone that occurs when a twisting force is applied to it. We see this a lot with abuse, child abuse, or abuse, where someone's grabbed and twisted an arm and it'll do a spiral fracture. And that kind of flags you to that. So those are those three kinds of fractures. So here's some more fractures. We've got a green stick fracture, and it's showing you the picture. It's kind of harder to see with the bone there, but it's what that is. It's a partial break in a bone, and it that causes it to bend or crack without completely breaking. So, and the reason why they call it a green stick fracture, it comes or derives from a branch splintering. So, you know, when you break a branch on a tree and it splinters down, that's kind of what a green stick fracture looks like. A simple fracture is a fracture that there's no skin broken. The bone is broken, but no skin has been penetrated or anything like that. We call it also a simple fracture. The compound fracture, as you see next to it, or an open fracture, the bone has not only broken, but has now come through the skin. They are at the highest risk for infection because we have come through the skin and we have an open bone. They're at a very high risk for infection. And so we have to be very, very careful with patients with compound fractures. The other thing is you can see that compound fracture, it's coming out through the skin. So it's going to come across where there's blood vessels, arteries, and veins. So we worry that a compound fracture can actually cut an artery and the patient could bleed to death. Or they could cause damage to those blood vessels and they're going to have trouble with blood flow. So there is concern for all of that with compound fractures. They're the worst. So if you look at the bone to the left, it's an oblique fracture. And an oblique fracture is the break in a bone. It occurs at an angle diagonally across the width of the bone and along its longitudinal axis. So you're going kind of across and down if you look at that. That's what it looks like. Usually, this type of fracture is after a fall or sudden impact from an angle, like a car accident. So something's hit it and made it, the pressure of the bone itself was hit, and then it fractures down that way. The next one is a comminuted fracture, and that's a broken bone that is split into more than two pieces. And if you look at that, it looks like there's multiple pieces. It's like a crush almost. There's just multiple fracture pieces of the bone. That's a comminuted bone. The oblique fracture can be, if it does that kind of fracture and goes out through the skin, it becomes an oblique compound fracture. So you can put terms together depending on what's happening. Simple is it hasn't gone through the skin. Compound, it's gone through the skin. So oblique, it's at that angle. Comminuted, it's multiple pieces. And then transverse is our next one. And that's where the bone that runs horizontally across the bone, perpendicular to its shaft. So it's perpendicular to the shaft itself. So we're looking at, do you see how it just kind of goes across like that? That's a transverse. So different types of fractures. I wanted to share this. So to treat a fracture, it's emergency care. We need to prevent shock and hemorrhage. Hemorrhage is bleeding out. Next semester, my students will learn all about hemorrhagic shock and how to stop bleeding. But if you came across a fracture and the patient was hemorrhaging, we would need to do things to try. We'd lay them flat. You know, we would not want to disturb anything. We want to splint it as it lies, meaning if you've got a bone going one way, you don't need to be pulling it and trying to put it back in place. That's not. You just splint it. We did that even in the field as flight nurse. I was a flight nurse. What we would do is take pillows and stuff and tape and other things that we had, and we would splint the area to try to cushion it and keep it from moving. We didn't want it to move anymore because we didn't want it to pop through the skin, but we would just leave it because that's a surgical physician thing to do, is to put it back in place. Now, tetanus, we want to make sure they have their tetanus up. If it's been less than 10 years, they're usually okay. If it's close to 10 years, we might give another tetanus. But we need to ask that as nurses. And then we're going to give prophylactic antibiotics. We're going to hang antibiotics to hopefully prevent infection especially if it's an open fracture. That's where they're going to be susceptible to infection. So different things going on. My son, youngest son, when he was in high school, he was running down the stairwell. We had carpet on the stairwell, and he kind of tripped. It ripped his toenail from the root of the toenail of his great toe out, and broke his toe. So the bone was broken, and then the toenail was ripped. Because the toenail was ripped and how it was ripped, it became an open fracture. So he had to take antibiotics in hopes to prevent any infection from it. And of course, healed. Everything was fine. But there you go. Very simple. Just the toenail opening that area created the open fracture. And that's something we need to be very, very careful with. Establish union between broken ends to restore bone continuity. That's the aim of treatment. They're going to put the bone back, line it up, and allow it to mend itself. And that's what bones do. They'll mend, but it just takes time. So you ask yourself, how long does it take to heal a fracture? Well, it just depends on where the fracture is and what's going on. So in other underlying illnesses, so in average, a minor fracture can take 6 to 8 weeks to heal. But a tibia, let's say, can take up to 20 weeks or more. And it all depends on how the bone is broken, what kind of fracture it is, the age of the individual. Are we looking at a patient with like osteoporosis or underlying health conditions or diabetes? That plays a role into this because we know diabetes can impede with healing and other issues. So this is a biggie. Usually the phase of the inflammatory phases, there's phases of the healing of the fracture, and I'll go over those in just a minute. We have closed reduction, open reduction, stabilization, internal fixation, external fixation. So we can go inside and nail things together. We can come outside and put pins, depending, casts, splints, and braces, and of course traction. Traction is seen. There's devices that are attached to the bone that go through, come out the skin, and they're attached. And there's weights that help pull the bone. It's going to pull it and keep the bone in alignment. You never let off traction, guys, because the bone will go right back and cause more harm. So we always keep traction. If you have to take them off the traction that's hanging, and I'll show some pictures of this, but if you have to, you want to hold the leg in place. Let's say it's a femur fracture and they're on traction. You would hold the leg out, and not allow it to go back into the original place how it was broken, not let the bone shift, if that makes sense. So internal fixation, we're looking at pins, nails, and metal plates. We have open reduction and internal fixation. We can have prosthesis. That's where they're going to replace the bone or broken with a metal plate or something. That's looking at like hip replacements, things like that, where we cut off the bad piece and hook in a new, ball or whatever. Autotransfusion is where these things bleed. When we're doing these surgeries, it's major and they're going to bleed. We can autotransfuse, and that's where we give their blood back to them. So they can have a lot of blood loss and we can give it right back. And so they don't really lose a lot of blood in this process. We'll give IV antibiotics to prevent risk of infection. We want to do prophylactic if there's any kind, and we've cut into them. So we're also compromising the skin at this point. And that surgical patients are a higher risk for infection. Our nursing care is we want to maintain good alignment with the affected leg, prevent complications of immobility. What are those complications? DVT, right? We can't move, so we're going to have to do what? We're going to give Lovenox. We're going to give something to prevent DVTs. We want to prevent pneumonia. We know if we've got to move for pneumonia, right? And how do we do it? Deep breathing, coughing, and using your incentive spirometer. It is a must. And we want to control pain. Pain is awful, and we need people in pain aren't going to want to heal. They're not going to do the things they need to do to get better. Okay, so we want to control pain. It's very important. And we want to watch and be very careful with the NSAIDs because they can cause bleeding, more bleeding. So we don't usually give those. We'll use narcotics, and we want to make sure people start moving around. I know hip replacements now, they are up and home the same day. It's a same day surgery, guys. They have their hip replaced. They come out of that anesthesia. They wake everything up, get them all, get them up, get them going a little bit, and they're put in a car and sent home to move. They want them to move. They have proven that people will have better outcomes if they immediately start moving. We do it with open hearts, guys. We've been doing it and we figured that out. We used to let open hearts lay there and they died. And so what happened is they said, no, they need to get up. So 4 hours, within 4 hours after extubation, they are to be sitting up on the side of the bed. They have to get up and sit on the side of the bed at least. And then they go back and then they're up in the chair the next morning, 6 o'clock. It's just what it is. And then they walk that day. So it's a lot. Patients are like, there's no way. But I will tell you, there is a way. So external fixation, we usually use these with massive open fractures where there's extensive soft tissue damage. So this, they're open fractures, they're out. We've got openings, things like that. We're going to externally fixate it. And external means outside, right? Infected fractures that do not heal properly, those are going to have to be opened and healed properly, cleaned out. We'll have external fixation. Multiple traumas such as burns, chest injury, or head injuries. We use external fixation for these. So this is just things that are indications for the need of external fixation. Here is a perfect picture of external fixation. You see the device is coming out and it's holding this bone in place outside of the body. So we have cast and fractures. So materials can include plaster and synthetic cast. We see that with our arms, and there's long leg and short leg cast depending on what's going on. You have a long leg, it goes all the way up, a short leg, it goes below. Slings, we have to sling, we can sling an extremity, an arm, and support it. We want our wrist and hand to be above or towards the heart, not hanging down, because what's going to happen is going to cause more swelling. And then there's spica casts. And what is a spica cast? It is known as a hip spica or a body cast. And these immobilize the hips, pelvis, and femur. They're going to help heal after an injury or surgery, depending on what's going on. It has an opening cut out for diapering or toileting. So you have this huge cast, but there's an area cut so they can still go to the bathroom and we don't have to, deal, or because we cannot not have that, right? Sometimes children will need a spica cast after breaking a bone in their thigh and hip surgery. And what happens, tendons release, and it can also be used, the spica cast, to treat hip dysplasia. And that's what we see with the little babies. They might have to, with hip dysplasia, wear the cast for 12 to 18 weeks. So, and the doctors change it every 6 weeks. That just kind of stinks, doesn't it? Can you imagine? Anyway, you should always lift your child by their cast, not under their arms, and support their head and legs with pillows. You should also turn them every 2 hours or 4 hours and check their toes, feet, and skin for warmth, movement, color, and make sure they have no breakdown. So you can't throw them in this cast and just let them lay there. We've got to be checking them. They're looking at those extremities, making sure that there's no discoloration, that they're warm, that they've got pulses, right? That they can wiggle their toes if they're able to, if they're old enough to take command. If they're not, you're just going to have to watch them to see if because they'll wiggle them, they'll move them. You can touch them and they'll move their toes. But that's what a spica cast is. If you're not familiar with those things, just look up those terms, look at images, and that'll help kind of visually help you with it. So here's a wonderful synthetic limb cast, and we can see it. Don't you love all the colors? I mean, you get to choose your color, and I think kids love that. We see a lot of fractures with kids because they do crazy things. They don't think they're going to get hurt, so they're jumping out of trees, they're doing all this stuff, or on trampolines. We see a lot of trampoline fractures, but they get to pick their color, and that makes it a lot of fun while the bone sets and heals. So we have different fractures. We can do a fracture boot. We've seen them. They're kind of big and bulky, but they help with people getting around. People really like them. Some people don't, but most people feel pretty comfortable. They prefer to go that route. We have a hinge brace. That's where it bends. We can bend at the joint with it. Knees go in it, elbows. We can put it at a certain degree, the doctor can, and lock it so that they immobilize it, but the knee is bent. We don't want anything to stay straight because we're not made that way. You want it to be at a natural. If you leave something straight, what's going to happen is they're going to lock and it's not going to bend once they come out of the cast or something, or the brace. So we want to make sure that we have it at a certain degree. And then of course there is a slab. Back slabs are usually used. They're called back slabs, and that's when the first line of treatment when a fracture is swelling or you've done a surgical procedure. It's that initial, and it consists usually of plaster, of Paris, wool, and bandages. The plaster will set in 3 minutes, but it takes about 48 hours to completely dry. It's going to feel cold and damp for the patient, and you need to explain that to them. You always want to explain the procedure, feel warmth as the cast sets and dries. Never put a fresh cast on plastic, and never cover a fresh plaster cast with a blanket. So here's a picture of walking boots. They come in different sizes. They can come up further. They can be for lower. It just depends on where the break, what's going on, and what we need to immobilize, right? That's what we're looking to do. Question: why do you not cover a cast until it's completely dry? What happens is it's not going to dry. The moisture will weaken the plaster and damp the padding next to the skin that can cause irritation. So we don't want to put a blanket over. We don't want to keep. We need the plaster cast to breathe and dry. Once it's dry, then you want to keep it dry. So if they go to get into water, if they want to get in the shower or something, you cover it with plastic, tape it so it doesn't get wet. We don't ever want it to get wet. It can cause a lot of problems. It weakens it, and it can actually cause irritation and skin breakdown because of it. I was in college, guys. I wasn't even a nurse, and there was a guy who had broken his arm. He had a cast on, and one night he had been, I think, partying a little. I'm sure. I was a RA, and I wasn't on duty, but my friend that was an RA was on duty. And so anyway, he was called. So we went over to see what was going on. He had he soaked his cast. He was a little intoxicated. He soaked his cast in water, and then he started taking scissors and knives and cutting the cast off of his arm. And we were like, don't do that. But you know what? He did it, and there you go. So when you look at skeletal traction, you think torture. I mean, you look at it and go, this can't be. But it's so vitally important. It's something that is needed for certain patients that have certain fractures and things that are repaired to keep that kind of traction so everything stays in alignment. So as the nurse, it's important. There's pins, wires, you can have tongs, where they directly through the bone at a point distal to the fracture so that the force of the pull of the weights is exerted directly on the bone. You are pulling directly on the bone with skeletal traction. Skeletal, key word. Skeletal traction uses 10 or more pounds of weight, and the body acts as counter traction. Interesting, huh? So as the nurse, what do you need to know about skeletal traction? Well, first of all, you've got to take care of your patient. You want to monitor the traction system. You should ensure the traction system is being used properly and safely. You don't want them, anybody lifting up off the weight or laying the weight in the bed. or doing anything weird with the system. And so you want to make sure everything is always in alignment when you go into assess, things are where they should be. You want to look at for side effects where the pins were inserted or there's limited movement. So the first few days, the patient may be able to participate in activities that keep them still, such as reading, watching TV, distract them, things they can do by looking up. Um, and you want to make sure you give them things to do because they're not going to be able to move. They've got to stay in alignment. It's not something there's no twisting and turning and doing things, getting up or anything like that. So we have to distract. Think of all those good distractors. Dim lights, they're laying back. They don't need to be staring at bright lights. How about turning on music? Things like that. There's a lot they could do. Television is always our friend. Remember that. People get tired of it, but it's there for them. They should check the patient's skin. All of nurses should be looking at the skin for signs and symptoms of breakdown and irritation, not only around the pin sites, but everywhere it's laying against. If it's got a cast on it, let's just say, or there's something, a bandage, anywhere there's injury, they need to be looking. But then also you need to be looking at where the pressure, the heels, anywhere but tissue is laying with pressure against, we want to make sure there's no breakdown. So we have to really keep assessing for that. They can get redness, flaking, blisters around the pins. So we need to do proper pin care, pin site care. You want to always check for swelling, pale and blue skin color, tingling or numbness and movement. So these are important things to look at. Always trying to see and make sure that they're getting good blood flow and there's no nerve damage. There's nothing that's causing or pinching off a nerve or anything or impeding blood flow because we got to have it to survive. And the appendage has to have it to survive, the leg or the foot or whatever. You want to prevent infection by the proper pin site care. You're going to clean around it. There's ways of doing. Mobilize the patient. Nurses should mobilize the patients to prevent complications. You're going to have to talk to your patient. You're going to have to talk to your patient's family, and you're going to probably have to talk to them more than once about it. And the reason why is you tell them, and then you give them good old pain medicine, knocks them out, throws them for a loop. They wake up, and then they're like, oh, I need to get up, or they feel they need to go to the bathroom or something like that. So you have to be patient with them and you have to understand. It's like making somebody who never wants to sit in a chair sit in a chair for a long period of time. It's not fun. Skeletal traction. So there's skin traction. So we're not attached to the bone. We're outside of it. And so what happens is you apply it. There's moleskin or foam traction boots. They're applied to the limb below the site of the fracture, and then the pull is exerted on the limb itself. So there's no more than 7 to 10 pounds of weight is used. This is where, as the nurse, you've got to look. How much weight is it? If you go in and there's 15 pounds on a skin traction, there's a problem, right? They can have continuous traction or intermittent traction. It just depends. But traction, remember guys, it's to limit movement. It reduces the fracture to help decrease pain. It's going to help decrease pain for them. It's going to help with spasms and swelling. So traction is important. It's either skeletal and we have skin, and we can use different things. And with skin traction, we can have continuous or intermittent. So you can have traction for a while and the doctor will tell you to take it off for X amount of time frame. So you'll take and you can, put the weight, the traction piece off so that then the body is there. You go, why do we need to do that? Well, with skin traction, you usually have intermittent because we worry about skin integrity. Do you know what I'm saying? But attached below the fracture, just remember that. Complications of fractures, as soon as you can fix the fracture, the less likely there'll be complications. So that's why when someone comes in with a fracture, if it's an open fracture or if it's a large bone, because you can bleed to death from a fracture of a large bone, a femur, a hip, they go to surgery pretty much immediately, depending on what the fracture looks like. The doctor is going to look at the x-ray and make those decisions. Sometimes people wait. just depending. Healing can be impeded by improper alignment and inadequate immobilization. So we've got to be very careful that we do it correctly. You never want a bone to start to mend and then they have to go and have it rebroken, go into the OR and they re-break the bone and have to then pin it back together and fix it and all that mess. None of that. Any continued twisting, shearing, or abnormal stresses will prohibit a strong bony union. So we want to keep it immobile. We want to keep it protected. We need it to stay in alignment, and the bone itself will start to mend. Pretty interesting. If you've never seen that, just Google search it. A bone mending and look to see if you can find a video or something that will show you that. But it's pretty nifty how the bone works. It'll fix itself. We're amazing. The body is amazing. So fractures and infection. If we have an open comminuted fracture or surgery where they've had to open up, we've broken into the skin, they're at high risk for infection. Can't say that enough. We want to give antibiotics. They're going to get medicines to help prevent infection. We might even just give prophylactic antibiotics. Prophylactic antibiotics is we're going to give it to prevent an infection, hopefully. If they've been out in the woods and they fall and have a major open comminuted open fracture, you've got dirt, you've got sweat, you've broken the skin open, they're at high risk. Bone is broken, it's open and exposed. They're at a risk for infection, so we're going to give antibiotics and hopefully prevent any infection. Infectious bone osteomyelitis is not a good thing, right? I mean, you can lose your bone if you're not careful. Inadequate calcium and phosphorus, vitamin deficiency, and atherosclerosis, these all can cause issues with fractures or have fractures. Healthy diet is so important. Calcium is needed for strong bone, but also phosphorus is a key ion that forms bone. So those are important. So if we have hypophosphatemia, we need to know, right? Phosphate if we're missing phosphorus. Calcium if we're hypocalcemic, that's an issue. So we want to make sure that we talk to, especially moms and dads, if you've got a child with a broken bone, we want them to have the adequate nutrition to help heal that bone back. And so they need to know they need to eat healthy and what they need to eat. Foods with calcium and phos in them. During fracture healing, the bone remodeling begins around the 6th week. So we get remodeling in that healing process. And that's when the regular bone replaces the hard callus formation. So this process requires constant supply of nutrients, including calcium, phosphorus, vitamin D, and potassium. We know that those are so vitally important. Don't forget the foods for calcium: milk and dairy products, green leafy vegetables, broccoli, almonds. Almonds is a good one. I love almonds. Legumes, seafood, calcium fortified foods. Of course, there's cereals, juices, milk, and milk alternatives, especially if they're dairy intolerant. There's ways of getting calcium. Tofu and nuts and seeds. Sesame and chia are in that mix with almonds. So that's important. Just FYI. Also, temperature, white blood cells, and wound appearance, that redness, swelling, heat, and purulent drainage are all signs of infection. We will be looking, documenting, and assessing these areas for these things, making sure we don't see signs of infection. We need to be on top of it. You want to be ahead of your game, not behind it, where you're having to treat them for infection. So every so often, the bone won't heal properly. You just have an issue. And so there's things that the doctor can do to fix this, hopefully, or help. They can do electrical bone growth. They're going to stimulate, and hopefully the bone will produce and heal itself. There's some surgeries that can take place, and bone grafting during the surgery. And so what happens with bone grafting, it usually can take about 3 to 6 months to heal once they graft it. So what happens is You have initial healing stage. It's about 1 to 2 weeks. It involves the graft material integrating with the natural bone. During this time, a blood clot will form around the surgical site to reduce the risk of infection. Patients are typically advised to stick with soft foods if it's a mouth thing, or avoid strenuous physical activity. We're not going to do any of that. The bone is trying to heal itself. We need to go easy, folks. Put the brakes on. Early bone formation, the stage usually takes 2 to 8 weeks. It involves increased cellular activity that leads to the formation of that granulation tissue. Blood vessels will begin to infiltrate the graft, and early bone formation will become visible on x-ray. So during that 2 to 8 weeks, they can x-ray and see if it's healing properly, if it's starting. It's in this process. And then we have bone remodeling. And what happens is this stage usually lasts 3 to 9 months, just depending on where and what and how. And it involves the body replacing the graft material with its natural bone. It's going to use the graft to hold things and start this process. And then our natural bone will take over and do what it needs to do. During this phase, the newly formed bone begins to mature and consolidate, becoming more stable. That's what we want. So you can look up different information on that, but that's about an approximate. So you need to know it takes a while for it to heal, and this is the process of the healing of that with a graft. Okay? So a rare but serious complication of a fracture of a bone is a fatty embolus. We never want that. Fat embolisms will kill. Think about it. Signs and symptoms. If your patient has a change in mental status all of a sudden, if they go into respiratory distress, they've got tachypnea, they're breathing fast, you hear crackles and wheezes, you have a rapid pulse, fever, petechiae, it's the rash. It's like it says a measles-like rash over the chest, neck, and upper arms or abdomen. It's a little purple rash that kind of goes. It's not sitting up on the skin. It's flush with the skin. But that's what petechiae is. Look that up, and that's a good word to learn. These are signs and symptoms of a fatty embolus. Our worry with a fatty embolus, and put this into your memory, is large bone fractures can cause fatty embolus. What are large bones? Femurs, pelvic, right? Those areas. They're big bones, and when we break them, a fatty embolus can easily form, and it can be deadly because if that embolus, that fat clot, breaks off and goes, it can shut down the respiratory system and kill them. Okay? It can go to the brain, kill the brain. So we have issue, we're worried. So this is life-threatening, considered emergent. But if you've got somebody with a femur fracture, you've got somebody with a big pelvic fracture, hip fracture, stuff like that, you want to make sure you're watching them for those signs and symptoms because you don't want them to throw a fatty embolus. Okay, if you have a fat embolism, nursing management for this, you want to stay with the patient. It's not a time, this is emergency. This isn't the time to go somewhere. You want to put them in a high Fowler's position. Why? We need them to breathe, right? We're going to drop that diaphragm and hopefully sit them up so they can breathe. Use a non-rebreather mask. You're going to put a non-rebreather. That's the one with the bag at the bottom. Review, for my students, review that. What is a non-rebreather? What do I turn it to? 10 liters or higher, right? The bag does not have to inflate to put it on. Just make sure you can feel oxygen coming through and it's connected to O2 before you put the mask on. Non-rebreather, it's going to give them 100% oxygen. Establish a peripheral IV, and I'm just going to go on record to state if they don't have one, put in two. If they've got one, establish a second. So you have 2 IVs. Summon the physician immediately. That means page them. Let's go. We need you. This is what's going on. It's an emergency. Anticipate hydration with IV fluids and correction of acidosis. So it's going to throw them, that fatty embolus is going to throw them into an acidotic state. Why? We're dealing with respiratory issues, right? And we're going to end up having to intubate and do mechanical ventilation. This is emergent. This is an emergency, but it's fatty embolus. Learn these things, guys, and why you do it. So back to fatty thrombosis before I talk about, or embolus before I talk about venous thrombosis. is one thing you need to know with the fatty embolus is that they'll have the tachypnea or fast breathing. They're going to have low oxygen in the body. So we're going to go into respiratory acidosis, right? We're holding on. We're not getting that good oxygen exchange. Symptoms will usually occur 24 to 72 hours after the break, the trauma. And so we're watching them for that first day to 3 days out, right? They're at a high risk. This is what happens is fatty little globules form and they release into the bloodstream. Well, that's not good. So we have that issue, but then we can have venous thrombosis, and we see this a lot, and we talk about venous thrombosis a lot because anybody can really be at risk for a DVT, right? Deep vein thrombosis. Um, Venous thrombosis can it's blood clots, and what happens is, hang on guys, what happens is I'm having troubles. It'll form, it's a condition that it forms blood clots in the venous, it's in the veins, right? So we're worried about that. It can break off, they can go to the lungs, they can go to the brain. People can survive. We usually give Lovenox, low weight heparin, and that's what Lovenox is, and to hopefully prevent them from getting clots. When we don't move, we can develop these. That's why anybody that's had surgery that lays in the bed, we worry about deep vein thrombosis or venous thrombolisms. So what we want to do is assess for those, looking for if they're going to have a DVT. So they can have throbbing of pain in the leg. It's usually rarely in both legs. It's one leg or the other. It's usually in the calf or the thigh. They can have swelling in the leg, and the leg can get very large. You'd be amazed. The warm skin around the painful area, it's going to be warm to touch. It's going to be very painful, and there's going to be swelling there. They can have a red or darkened skin around the painful area, and this may be harder to see on brown or black skin, of course. So, but it's still going to be discolored. Just look. That's why assessment is so important. I mean, unless someone's really, really dark, you should be able to see a difference in skin tone or skin color. So it should, if there's darkening, you'll see it. So we can, sedentary due to bed rest or sitting too long. That's why it's so important too that we make sure that we look at casting and how we lay people. If people are in traction, they're going to be at a higher risk for this, right? So it's so very important that we watch and look for this and really assess those that have had injuries, any kind of surgery, but definitely immobility, traction, and cast can contribute to venous stasis. And that's what causes these clots. So you want to put compression stockings on, sequential compression devices if possible, and range of motion exercises on the unaffected lower extremity. I went one day in with a student. This is after I was nursing. I was teaching at this point. And we went in and they had SCDs on a fractured leg. I about had a heart attack. I said, let's just turn that off and let's just clarify. And we did, and of course it didn't need to be on there. Somebody didn't know. But you put those things on the unaffected extremity to hopefully prevent them from getting a DVT. Okay. Also, we don't want them to bleed out, but we also need to start that Lovenox in prevention of as soon as we can, and the doctor will order that. Okay. So it just depends on what's going on. So we've talked about rheumatoid arthritis, and now we're going to talk about osteoarthritis. RA, we talked about the last unit that we learned. Now we're going to learn about this one. So osteoarthritis, just so you know, it's a non-inflammatory degenerative joint disease. It can affect any weight-bearing joint. We can see it pretty much any joint, but mainly weight-bearing. The risk factors of heredity, right? If your grandma had it, your grandma, your great-grandma, all your aunts, you're probably going to have it. Mom, whoever, we can look at that. Aging can cause it. females are more at risk. They are 60% at more at risk of developing this than men. And the reason behind that, guys, is the hormone. There's estrogen levels fluctuate as we age. Over 50, we become a higher risk, of course, for this because of menopause. We're losing lower estrogen levels. And because of that, we start to have bone destroying cell production. We have the increased bone destroying cell production. So our bones start to dissolve and disintegrate as we age due to hormones that are changing. So that's why one of the biggest push for women to take estrogen after they're in menopause is so that they can be at a low risk for osteoarthritis. That's why we want to do bone density scans on females. That's why we want to try to hold on to the bone as much as possible and not allow it to be destroyed from this. So there's different things that we can do. But you have to remember, when we go to replace estrogen, it can make us at risk for higher female cancers and things down the road. So, it's, do you want this? Do you want that? It's what all you want. And then if you get, unfortunately, breast cancer or female cancers, then you are not able to take any hormones at all because they believe that those hormones can feed or create more cancer, and we don't want that. So interesting. It's a what do we do kind of thing. But there are ways to do and prevent. One thing is to remain very active, also stay as healthy as possible. But unfortunately, aging is part of this, and we start to just break down. And once again, as I always say, aging is so depressing, isn't it? But it's not. We can actually age gracefully and do it in different ways. So let's look on further with osteo. So osteoarthritis, the signs and symptoms, asymmetrical. So what's interesting about this is that it doesn't usually affect both sides of the body. So let's say it affects your knees. Your right knee might have osteo, but your left wouldn't. So it typically affects only one or two joints. It doesn't really go symmetrical. It can. It's not just the only thing. But what's interesting is a lot of people have asymmetrical osteoarthritis. It's on one side and not the other. It's on one joint, not the other joint. Just depends. The chief symptoms that we see are aching pain with joint movement and stiffness, limitation of mobility. The joints will get stiff. They hurt, hard to move. Joints can be deformed and nodules may be present. Herbadines nodules. It's where you see them on the fingers, these little nodules that can develop. So when you go to a rheumatologist, which is the physician that would be looking at someone with different kinds of autoimmune and arthritis issues, they're going to look at that and see what's happening with your joints. Let me just make sure I cover everything. It is a chronic condition, osteoarthritis. It can affect any joint. It's common usually though in knees, hips, spine, and small joints in the hand. That's why our fingers, bending and moving our fingers, we feel it there. They can have pain, swelling, stiffness, and difficulty moving the affected joint. Over time, what happens is we have reduced movement that could lead to muscle weakness and make it harder to perform or physical activities. So there are ways and things that we can do to keep us moving and hopefully manage it. One, obesity plays a big role. Obesity also can cause osteoarthritis. What is one of our biggest issues in our country is obesity. So we're going to have people with really hurt, issues with their joints, with osteo. They're going to present with it. So maintain a healthy weight, avoid overusing damaged joints, and exercise to strengthen the muscle that support the joint. And that's something to think about. So one of the things as we age too, we lose muscle mass. So we need to maintain muscle through exercise and diet. We need to stay healthy. and keep things in a line. A muscle will help keep joints, everything moving and keep things. It's the strength. That's why if you have issues with your back, you need to go to physical therapy and let them teach you exercise to strengthen the muscles that support your core, right? Because if you have a strong core, then you can support that spinal cord and you're not going to probably have injury when you do things. If you don't, you got a big old belly and you don't have much muscle there, and you've not worked on that core, you'll probably have a back injury if you get active or do something. There's a possibility. Let's go with that. So a little bit about signs and symptoms of osteo. So kind of the things I just said, we are going to deal with pain management, which includes acetaminophen and NSAIDs, of course, and we need to run all of these things by the doctor. We want to make sure that they're okay to take with whatever they're taking. Remember, these things filter through the liver and the kidneys, the renals, and because of that, we need to make sure we've got good kidney function. They can damage these things if we're not careful, if we take too much of these meds and stuff. So we need to really look and do every 3 months looking at liver function, looking at renal function to make sure things are okay. We want to strengthen, of course, and with aerobic, strengthening and aerobic exercises, we want to strengthen those muscles. We want to get in shape, feel better. We want to reduce weight if we're overweight. And the more you move, if you've not ever heard grandma or grandpa say this to you, I'm going to say it to you. Keep on moving. That's how you don't stop moving. People will hurt and want to lay up, but all that does is help freeze up that joint, and it makes it harder to move. Try to move through, use the NSAIDs, things like that. Some people like to use warm therapy, heating pads or something, but just remember, going back to this, we don't want them to burn themselves. If they've got diabetes on top of this, if they have neuropathy, we don't want them to burn themselves if they're using a heating pad or something like that. But sometimes it can make the joints feel better with that. And there's some other alternative therapies. I know a lot of people are using CBD oil. I mean, I'm not promoting it. It's something that's considered natural, homeopathic out there. There's rules and laws. We can't use it as nurses here in the States because they consider that to be still under the influence. So don't start using it. I know it's against the law in Florida. There's some states it's legal. It just depends. And anything you do as a nurse, and I'm going to say this, if you're treating yourself as the nurse and you have osteo and you want to use a homeopathic or an alternative holistic type medicine, then you need to make sure you check the board of nursing, make sure it's within the rules for you to use, because you don't want to use something and you end up in trouble or lose your license. It's just not worth it. But something to think about. There's stuff out there, guys. So, osteoarthritis, nursing management. Remember, we want to balance exercise and rest. They need to exercise so that they can strengthen that muscle, do those things, and but also rest. It wears them out. They can overwork, it just takes a lot on the body, so we need to make sure we do that. Moist heat application, that's a good thing, right? Get in that hot shower, get in that hot bath. Encourage to maintain weight within normal limits. So we've talked about that already. There's imagery, relaxation, and diversion to help. Quadricep strengthening exercises may relieve pain and disability of the knee. So I'm going to say this to you, utilize other resources. If they're in the hospital, they have osteo, they're having a lot of issues with this, or you're working in the doctor's office, their insurance might cover for them to go have physical therapy. And that's a great thing. They can teach them different strengthening exercises that can strengthen and help relieve pain and discomfort, and also create a real strong core and skeletal structure that will support the joints. And that's important with osteoarthritis. So I brought RA back for a second because we're going to talk about hip replacements. So when we're looking at that, surgical intervention and orthopedic devices, if you look down on this, there's joint replacement, total hip replacement, including preoperative and postoperative care of that. That deals with RA. That can deal with a joint for other reasons. Also total knee replacements. So those are two major. And just FYI, it takes longer and it's harder for a total knee replacement to recover than a total hip. Kind of interesting. So things to remember in your discharge teaching for a total hip replacement, it is okay to lie on the operated side. For 3 months, you should not cross your legs. You shouldn't cross your legs at all for circulation reasons, but for 3 months, they should not cross their legs. We don't want to cross over that line down the center because the hip is set up a certain way. If you come across, they say you can possibly pop out that joint, things like that, do damage. Put a pillow between your legs when rolling over or lying on your side in the bed. And it is okay to bend your hip, but not beyond a right or a 90-degree angle. And you want to teach them what that is. You want them to do it. You want them to show them. If you're sending them home, this is what they need to do. Avoid sitting in low chairs. And why is that? Because we're going to bend more than a 90-degree angle, aren't we? If you're in a low chair, your knees are going to come more up, and that's going to make that angle more narrow. And we don't want that. Continue the daily exercise program at home. They're going to go home and immediately they need to be walking. They're going to use a walker. Review walker, how to teach someone to use a walker. Review that again. You need to understand that. They're going to be on a walker until they're able to go to a cane. And then from a cane, they'll go to walking on their own. This is a long process. It doesn't just happen overnight. And we need to understand that there's a lot of pain involved. And if you've never watched an orthopedic hip replacement surgery or a knee replacement, you need to Google search that. I mean, it's like they're building a house. If they lay it to them. And so you want to watch that, look at that, and you can understand. It just makes me cringe, the thought of it. But like I was saying earlier, with total hips, they're no longer in the hospital. They go have the hip replacement. If they've got someone who can help them at home, they will send them home. They'll send them home for care. It's same day surgery, in and out. And then usually within the week or the second week, they'll have physical therapy start working with them directly, and a home health nurse will also come out. Pain management is huge with these patients. And then let's talk about it. Who breaks their hips or need total hip replacements? Elderly people, mainly elderly females, because of the low estrogen and changes in hormones, postmenopausal. So with that and saying that, what do we know about elderly? Well, we lose nephrons in the kidney. We don't filter as well. The liver doesn't function. Things slow down. Things don't work. And so if we're going to give them pain medicine, what happens to it? It can make them loopy, can stay in their system going through. They can't filter it out. And can you walk with a walker? You're already in pain and then you have pain meds. So you got to be very careful. And there has to be a way of looking at how to treat. No NSAIDs at this time post-op. Not until the physician says to take NSAIDs. And the reason behind that is the fear of bleeding. So osteoporosis. We looked at osteoarthritis. Now we're going to look at osteoporosis. The etiology and pathophysiology of osteoporosis, we can have osteopenia. And osteopenia is the initial stage of bone loss. It's the first piece. So a lot of times, women and men can go have bone density scans done, and they can say they're osteopenic. And that means at this point we need to do something to intervene before they get worse, because osteoporosis is the more severe condition without treatment. That's what happens. So if you get osteopenia and you don't do anything about it to make it better, then it's going to lead to osteoporosis, and that's worse. Risk factors for osteoporosis: age. The older we get, we talked about it, over the age of 50 for females, right? And I am sure there's a specific age in your ATI book for my students. If it is, that is the age you need to know. But I always average it over around the age of 50. And the reason why is most females go through menopause or start menopause around that age. So that makes them at the higher risk. As we age, we lose bone density and all of those good things, unfortunately. Chronic diseases out there that can cause osteoporosis, anything that's going to leach calcium from the bone, or a vitamin D deficiency, is going to cause issues and cause osteoporosis. There are medications out there that we can take that will cause osteoporosis or leach these things from our system, and that's bad. Smoking is another one. If you're a smoking female, stop, because you are only opening yourself up to higher risk for many things as you age. Excessive caffeine or alcohol intake. I'm gonna have to look away on the excessive caffeine because I love my caffeine. Coffee, Diet Coke drinker. But we shouldn't be drinking it in excess. It can cause issues. And sedentary lifestyle, because we know that if we weight bear, we're going to force calcium back into the bone, right? Weight bearing is good for our bones. We need it. You can't just do passive range of motion and keep things the way they should be. We need to have a diet rich in calcium and vitamin D so we can absorb that calcium. And bone strengthening medications can help treat both osteopenia and osteoporosis. The best thing you can do for osteopenia, guys, is physical activity. Stay active, strengthen your bones, and we do that, like I just said, with weight-bearing activity. Walking, whenever we jar that, somebody told me a long time ago, whenever you feel that jar to the body, whatever you're doing, if you're physically doing something, that's helping those bones stay alive and well. I think it was my anatomy teacher. Vitamin and mineral supplements we can do too. There's over-the-counter stuff. We can take it. We want to just make sure that we're doing that so that we replace what we don't have. This is kind of interesting. Experts estimate that more than 40 million Americans have osteopenia. They think around 1/3 of the adults are over the age of 50. There you go. These are some conditions that can cause osteopenia. And just remember, they'll worsen osteopenia, which leads to osteoporosis, hyperthyroidism, diabetes, chronic kidney disease, malnutrition, of course, hormonal imbalances like Cushing syndrome, not just menopause, anorexia and eating disorders, and autoimmune diseases that affect the bone, like rheumatoid arthritis or anything that depletes collagen or causes collagen defects. Diuretics, medications that increase this. Listen to this, guys, because we give a ton of it. Diuretics, corticosteroids, medications to treat seizures, hormone therapy for cancer, breast cancer or prostate cancer, anticoagulants, and PPIs. These are things that leach from the system, so that you know. Interesting, interesting. We can do bone density scans and other things to see what's going on. So osteoporosis signs and symptoms, there are no early signs and symptoms. Height loss, though, we can see kyphosis, that's the hunching of the back, and compression of the spine. The spine will start to break down. Diagnosis, bone radiographs, also DEXA scans, you'll hear that, and they're reported. The way a DEXA scan works is they scan the bone and then they compare it to across a mass number of people of your age of what the bone looks like. And that's how, and it's a percentage. They report, it's a score, it's called a T-score. And so they go through and they have a scoring and they look at that, and then they can then say you are appropriate for the age that you are or you're not. And that's how they can diagnose osteoporosis and osteopenia. Just FYI. So once again, and I'm not going to read this is getting to be a long thing, but this kind of embraces everything you need to know for this unit. Treatment, stop bone density loss. We talked about it. Prevent fractures, increase bone formation. How do we do it? Those are our goals. We're going to do estrogen replacement therapy for females that are postmenopausal. But, and I say a but with that, if you have cancers, breast cancer, any kind of female cancer, you cannot take the estrogen. The hormone replacement cannot happen. It's a big no. So those women are at more or higher risk for osteoporosis because they can't take the hormone replacement. Adequate dietary and supplemental calcium and vitamin D, we talked about it. There's also phos in there, remember that. There's the biphosphonates, that needs to happen, parathyroid hormones, and weight-bearing exercises. Again, if you don't know what weight-bearing exercises are, I suggest to my students do a Google search, look for something that's legit, or go through your book and look at weight-bearing exercises. So there's two things with osteoporosis. We can have vertebral fractures. Actually, this happened with my mother, believe it or not, but it's very, very painful. And the picture below it is a kyphoplasty. And what this is they go in and they put like the cement within the bone, the spinal cord there, because it depletes. And if you look at the kyphoplasty, you can see number one starts to the left, and you see the compressed vertebrae, and then they balloon it open. They put in a catheter and they balloon it open where it's been compressed. See how it's opened in number 3? They balloon it up open back where it's supposed to be. Then the balloon is removed and cement is inserted. You can see it on x-ray, guys. When you x-ray someone that's had a kyphoplasty, you'll see a big white blotch there. That's the cement. The cement will harden, restoring the vertebral height. So we start to break down. It becomes very painful. We see it with the elderly. It can happen in different areas of the spinal column, usually in the lower. And then what happens is we can come in and fix it this way. Now, a vertebroplasty is the other, and it's about where we're going and how we're doing it. So when we're looking at that, it's minimally invasive spinal procedure. It involves injecting bone cement into a fractured vertebrae to relieve the back pain and restore mobility. So it's very similar, but it's just a little bit different how it's done. It's often used with compression fractures from osteoporosis. A small hole is made in the skin and a catheter is inserted again. The area is numbed. And then they just put the cement in and it'll harden around. And there's two different. It's a more conservative approach, the vertebroplasty, but a lot of people think it works well. Doctors are doing it left and right on people, and it's really helping them. We also need to have give them pain medications, activity limitation, physical therapy, and embracing needs to take place with vertebral fractures. We got to start to strengthen things, and we've got to control and make sure things heal the way they should. They can't be getting this done and twisting and doing things once they're repaired. And they're not going to feel like doing that until it is repaired. They're in excruciating pain. So if we're going to jump from one, let's just jump to another. Let's go to amputation. Whew, that's a biggie, isn't it? Let's just cut stuff off. So lower limb amputations are related to peripheral vascular disease, diabetes. We see it with diabetics, right? Neuropathy. Resultant gangrenous tissue will not heal. It has to be cut off and gotten rid of. Severe trauma, malignancy, congenital defects, depending on what's going on. And we see amputations with military injuries from shrapnel and landmines. We see a lot of our men and women that go serve our country come back with missing appendages where they've been blown up or whatever that's caused them this injury. Upper extremity amputations are brought on by crushing blows, thermal and electrical burns, lacerations, severe, vasospastic diseases, and malignancy and infection. So what happens with vasospastic diseases, things clamp off, we're not getting blood flow, things die, and then it ends up that it has to be cut off. Because once tissue's dead, there's no bringing it back. Just remember that. So if by chance you have an accidental amputation, this is what you need to do. You need to rinse the detached part only enough to remove visible debris. Not time to clean the kitchen, not time to scrub the toilet. You want to just rinse off if there's just, big leaves or something, get those things off because you don't want things laying on the tissue. Wrap the part in a clean, damp cloth, damp being the key word. We don't need things to dry out. It won't reattach if they can. Place the part in a sealed plastic bag or in a dry, watertight container. So we want to seal it off so air's not getting to it. We're trying to protect this. Then we want to immerse the bag or container in a mixture of water and ice. 3 parts water, 1 part ice. Do not let the part get wet or freeze. So it's so important we're protecting the tissue. But we need to you're going to put it in something, seal it before you submerge it. I've had people walk into the ER holding a cup with ice and a finger stuck in it. They said, well, they told me to put it on ice. Well, good luck. But what we want to do is do it in this way. This is a good little slide right here to look at, because if you have an accidental amputation, you can hopefully save the part. And I'm going to tell you, surgeons are miraculous. They can reattach a whole lot of things. You'd be amazed. So here's another care after an accidental amputation. You want to alternatively place the container in an insulated cooler filled with ice if possible. So we want to keep it cool because tissue will break down and die if it gets hot. If no ice is available, though, keep the part cool. Do not expose it to heat. It's like cooking a piece of meat. We don't want to do that, right? Tag the bag or container with the person's name and the name of the body part and take it to the hospital with the person. I'm going to say this too, even if the part is not able to be reattached, you want to always make sure that anything that comes off of a human being goes with that human being, because culturally, there are cultures out there that want to be all parts buried with them. So let's say they lose an arm, they're going to bury their arm at the grave site. And then when they die 20, 40 years from then, they'll bury with their arm. There's just different cultures that want their parts in pieces. And so you want to make sure you always label it, because what happens is they'll go down to the morgue. You might send an arm or a leg down to the morgue, but always make sure when it's come through the ER, we know whose it is and what's going on. I had a gentleman that's leg was ripped up high off of a cement truck. It lost its brakes going down the mountain. It threw him from it and tore the leg off as he went out. I'll never forget it. I was on scene. We got him ready to load. I had to go get the leg from the fireman, and he was a tall guy, so the leg was long. They put it on a big black bag full of ice, so I had to throw that thing in the helicopter. Oh, it was awful. And then I looked down and the bone sticking out of the bag from the leg. It was a hot mess. No, it did not reattach, but yes, he did survive. And I was very pleased. He was a young guy with a family. So, yeah, it was just surreal if you could have been there and seen that. So with an amputation, I love this picture. You see this woman running. There's hope. People that lose limbs, they don't need to throw in the towel. There are so many prosthetics out there that they can use to have a full life. So preoperative care, patient needs to participate in the decision making. They're the ones that have to lose the limb or the part of their body. They're going to go through the stages of loss and grieving. Kubler-Ross, we need to remember it. Anger. Eventually they'll come to acceptance, we hope. But they go through that. They can't believe it's them. They're going to, bargain. Why me? If I do this, why can't I? They'll go through that process, and you need to help them through it. It is a grief to lose a part of your body. They're going to have phantom sensations. You need to understand that. They might say, oh, that's just hurting. My toes are hurting, and the leg's been taken off above the knee. They'll have phantom sensations still in the brain, and that's something with the brain. And it's kind of interesting. So don't disregard them. Just explain to them that that can happen. And they're not crazy. They need to know that. And physically preparing, muscle strengthening exercises if they can. If there's something that they know is going to have to come off in time, they can start to prepare. Not if it's an accidental thing, that's a shocker, right? It's just gone. But if there's something that down the road they're going to have to take the limb, then you can start to muscle strength and get prepared, because it's not easy using a prosthetic when you have to get your leg put on, a prosthetic leg put on or anything like that. There's a lot to it. And the stump where they removed it, there's prep to that stump. You wrap it and do things to make it small and fits down in. There's a lot. So the amputation post-op care, hemorrhage and edema of residual limb. It's something that we're going to worry about. So to prevent that, we're going to elevate the stump for 24 hours. We're going to monitor for excessive bleeding. We're going to be looking at that dressing. If you see bleeding, we want to make sure we circle it. We're going to let the physician know. We don't take that bandage off. We'll reinforce it if we need to, but they're going to have some bleeding, but excessive. So think of it that way. Is it saturating those dressings? That's excessive bleeding. And dressing care, what to do and how to do. There is stump care and how to put a dressing on a stump. You need to look at that. There's a way of doing that. And we always wrap down and up towards the body, never up at the body and down. Just remember, because we want to kind of push fluids and prevent swelling and everything back to the main part of the body. Phantom limb sensations. We can give miacalcin IV infusions. There's transcutaneous electrical nerve stimulators. We can stimulate those nerves. And there's a stump stocking. So we can just make sure we hopefully can help prevent some of that and help them through it. So just different things that we can do post-op care. I do want my students to look up miacalcin IV infusion, know what that is. And for all of you out there, if you're listening and you're not one of my students, look it up. It's a good thing to know. So there's different things we can do with the stump post-op after the amputation. We can use a soft dressing with delayed prosthetic fitting. If they're not going to have their prosthetic fitted for a while, they can have a soft dressing on it. We need to do a rigid plaster dressing if we're going to have early prosthetic. We are going to form that stump so it can go down into the prosthetic limb. So, and then we have a rigid plaster dressing that we can use for immediate prosthetic fitting. The neatest thing, we see a lot of fresh amputations, but we don't usually see them down the road. So if you ever have a patient that's had a prosthetic, that uses one, had an amputation a long time ago, take a look at their stump, take a look at their scar, take a look at their prosthetic and how it fits. It's kind of interesting. How it works, because we need to make and form, and we can, so that it fits down in there. It's hard to put that big kind of, I don't want to call it fat, but it's a big, thick looking swollen stump down into something. We have to form that and have it ready to go down in there. There's a lot of discomfort with this, guys. They're going to feel a lot. So we need to make sure that we work with them through pain. And also we need nutrition. Lots of people lose limbs due to diabetes. So we need to control blood sugar so we can heal. They need to heal. And to do that, we can't have syrupy, sugary blood, because that doesn't help, does it? So there's things that we look at with post-op care, and we want adequate healing and weight bearing, right? If it's a below the knee amputation, it's better to begin walking and weight bearing than above the knee, because it's just where the pressure is put. If it's below the knee's going to help absorb and help things, right? It's also smaller. If we're above the knee, it's larger. You're also going to take everything to the hip. Think about it that way. Where are we taking it? And that's part of that. We can have abduction contractures, and so we want to make sure we have proper positioning of this so we don't get those. I want you guys to look up abduction contractures. Adjusting the new center of gravity. They're not going to be stable. We're used to standing on two legs. You lose a leg, guess what? We're standing on one leg. It's not so easy. Safety is huge. We want to make sure that they stay safe, that they don't fall. They're going to feel different. It's going to be hard on them. And so we need to be supportive. Don't dismiss them. Be supportive. It stinks. It is. But we can do this and we can do that. You want to also make sure that you're calling and getting physical therapy, having the physician make sure we're getting things set up. We also need to look with social work because they're going to need things for the house as they go through this. But we want to teach them stump care, how to take care of it, activity and weight bearing and exercising so that they can get ready to be fitted for a prosthetic and also that they can heal. And they need rehab. They're not going to just go home and heal. They need to go to rehabilitation and learn a whole lot. Because guess what? Once they get that prosthetic, they've got to learn to walk with it or use it. If it's an arm or a leg or whatever, they're going to have to learn to use it. And that is a whole nother ball game too. And they're going to have to learn to walk again with it. And they're still not going to have that center of gravity like that you normally do. But it's awesome to see people who come back from these and they race and run. I mean, they run faster than I could ever run in my entire life. So there you go. So there is things that can happen, and there's new stuff out there every day for people to live a very good life and a productive life. It's doable. So to wrap this up, this is a great picture. I loved it. It's a couple dancing. And if you look down, you can see she's got her dress on. It's stopping her from anything, but she has a prosthetic leg and it goes all the way. It's a full leg. And she's got her boot on it and she's out there just having a good time. And so life doesn't have to stop if the amputation happens. They need to grieve through it. They need to see what's out there, and they need to be put in the right places and with the right people. And as the nurse, that's something we want to make sure that we get the ball rolling when they first come in the hospital so that we can discharge them home and discharge them from the hospital to get the rehab they need, to get the prosthetic that they need. And there's funding with this too, guys. There's money involvement, just different things, but we can help them as nurses and get them through these hard times. I hope this video helps.